Uh, Namaskar, dear viewers. Welcome to today's session of Critical Care Webinars. And today is our international faculty webinar, and we are indeed honored. And it's my great pleasure to have with us Dr. Katerina Vaporidi. So, ma'am is Associate Professor in Intensive Care Medicine, University of Crete School of Medicine. She's also a physician at the ICU of University Hospital of Heraclius, and her area of interest, research interest, is pulmonary critical care, and she has done a lot of work on respiratory drive specifically, many articles and a lot of detailed work on respiratory drive. And I think she's one of the leading luminaries as far as respiratory drive is concerned. And we really thank you, ma'am, for talking to us on respiratory drive, which is a very important topic, and you having so much knowledge and so much work on respiratory drive. It's a pleasure and honor to have you with us. Thank you so much. And with that, I think, ma'am, we shall get the session going.
Thank you very much. I would much rather be with you there in India than in my bedroom giving this presentation, but hopefully next time. So let's begin. In the next few minutes, I will be discussing the definition and the determinants of respiratory drive. And that means I will be talking to you a little bit about the control of breathing. Then we will focus a little bit more about what happens in critical illness and during mechanical ventilation. And we will finish with the clinical implications, how we measure respiratory drive in our critical ill patients, and a more bedside approach to the problems related to respiratory drive. And many of what I will be saying, you can find it in this review published about 5 years ago in the Blue Journal. So the respiratory drive is defined as a slope over time of a signal that would ideally be the output of the respiratory centers, so the upper motor neurons, but this is something that we cannot measure. So we refer to respiratory drive as in signals that are further downstream in the inspiratory flow generation pathway. The signal of the phrenic nerve over time, or of the muscle contraction over time, or of the volume over time, that is the inspiratory flow. Now, let's start with the difficult things. The control of breathing system is located in the brainstem, and it is a network of interconnected neurons that regulate our breathing. The inputs to our respiratory center include the chemoreceptors, regulating blood gases, oxygen, CO2, and protons. Peripheral lung, muscle, and joint and other receptors, mostly activated during exercise, but also involved in volume-related reflexes. And also inputs from the cerebral cortex and the limbic system, involved mostly in the voluntary control of respiration. The output of the respiratory centers is an integrated signal that has taken into consideration all these inputs and modifies the timing, that is, duration of inspiration and expiration or inspiratory pause, respiratory rate, but also the intensity of the breath, how strong every breath is, and which muscles are going to participate in the inspiratory and expiratory phase. And this signal is what regulates our breathing. And think about this in a closed loop system where the respiratory center sends a signal, and depending on pathway integrity, that is the nerves and the respiratory muscle junction, it is transformed in a signal that is the contraction of the respiratory muscles. This contraction of the respiratory muscles, depending on the respiratory system mechanics, will be translated into tidal volume and with a respiratory rate minute ventilation. That, depending on the gas exchange properties of the lungs and the dead space ratio and the CO2 production, will result in the blood gases that will be sensed from the chemoreceptors Let me get my pointer here. So the loop closes here with the chemoreceptors sensing the changes in blood gases, signaling back to the respiratory center to modify again the next breath to adjust the blood gases to the target. So let's start by the very basics of chemosensitivity. Our ventilatory response to different levels of PO2. These were experiments done in the early 60s and 70s where healthy subjects were breathing different oxygen and CO2 mixtures. So what we see is that the response to decreasing levels of oxygen has two parts: an initial flat part at higher oxygen levels and an exponential rise at lower levels, with the rise being greater at levels below 60 millimeters of mercury. Also note here that the level of CO2 changes the hypoxic response, the slope, the exponential rise being much greater at higher levels of PCO2 and quite blunted at lower levels of PCO2. And then we come to the response to CO2. This is the change in ventilation for a given change in PCO2, also called chemosensitivity. This is a linear change, so characterized by a slope. When we are asleep or sedated, this slope intercepts the x-axis to a point called the apneic threshold. This is the threshold below which breathing briefly stops until CO2 rises again above this level. When we are awake, we do not stop breathing even when we become hypocapnic, and the slope takes this J shape, and this flat part at hypocapnic levels is called wakefulness drive to breathe. Note here that the slope is shifted upwards at lower levels of PO2 and downwards at higher levels of PO2 at hyperoxemia. So both CO2 and oxygen change the response of the system for each other. And the response, the change in ventilation, is much greater when we have asphyxia. This system is built to protect us from asphyxia with a very strong response. Now, we can summarize again the inputs to the brainstem, including the oxygen, the blood gases, chemosensitivity. The cortical inputs may, if not voluntary modulation, but also pain, fear, or anxiety, and then exercise. But we'll be talking about the critical ill patients. So for the critical ill patients, exercise is not really an issue. And in the ICU, most of the time, we are able to deal with pain, fear, and anxiety of our patients. We are also quite good at managing PO2 by mechanical ventilation, giving supplemental oxygen and correcting vacuum mismatch by PEEP, leaving PCO2 a very important or the most important determinant of the ventilatory demands on the critical ill patient. So we will be talking a little bit more about the PCO2 and the chemosensitivity. So what is called the apneic PCO2, the level of PCO2 desired by the brain, is the intercept between these two curves, the metabolic hyperbola, defined by this equation. So it depends on the CO2 production, and it's inversely proportional to alveolar ventilation. And this curve gives us the change in PCO2 for a given change in ventilation, depending on dead space and CO2 production. And we have the CO2 response curve, which is the chemosensitivity, as we talked about, which is the change in ventilation the respiratory centers demand for a change in PCO2. At the crossing point is the naked PCO2. Think about it like the cardiac output and venous return curves. It's a pretty similar concept. So the ventilatory demands when are at this crossing point to have in this situation with this slope and this metabolic hyperbola, this CO2 production and this VDVT, we have a PCO2 of 40 with a minute ventilation of 6 liters per minute. If disease changes the metabolic hyperbola shifts it upward, and this can happen with increased CO2 production or with increased dead space. Then, and if at the same time we have a condition that shifts the CO2 slope upwards and to the left, then our ventilatory demands will be much higher, almost 13 to 14 liters. And the brain will desire a PCO2 of 36 or 37. So the respiratory drive of a patient with this kind of disturbances is the one demanding to create a minute ventilation that is more than double the resting ventilation. So what changes the ventilatory responses to PCO2? Acidosis and alkalosis are important determinants of the slope, and metabolic acidosis shifts the slope upwards and to the left, while alkalosis has the opposite effect. Experiments done in the 60s in healthy subjects who agreed to consume for a week quite large amounts of ammonium chloride and then perform these experiments breathing different mixtures of CO2 at different levels of PO2 gave us these results. These are quite interesting experiments that we would never be able to repeat in the modern area of bioethical committees. So you can see here that after acidosis, the CO2 slope of this healthy volunteer was shifted quite a lot to the left and upwards. Other factors that shift the slope, again, experiments in the early 60s, is temperature. With fever, the slope is shifted upwards, but also shock. Norepinephrine infusion in these healthy subjects increased the slope upward to the left. This has also been observed in clinical conditions such as heart failure or cirrhosis, where it is known that patients have high levels of catecholamines, and it has been shown that the CO2 slope is shifted upwards. Now, another condition that is quite common in critically ill patients is inflammation. Now, in the 60s, they did not do this experiment, so we don't have results from healthy subjects having inflammation induced in their lungs. We have animal experiments, and in both non-sterile and also sterile inflammation, it has been shown that the lung inflammation is also translated in brainstem inflammation and in increased respiratory rate. There is just this one experiment that I could find in mice showing a small but statistically significant augmentation of the CO2 chemosensitivity in mice subjected to bleomycin-induced lung injury. Another thing that is common in anesthesia and critical care is sedation and opioids, and we use them, among other reasons, to decrease the respiratory drive, the responsiveness to oxygen and CO2. In anesthesia, we use it for anesthesia, and this is a side effect, but in the ICU, we may use it for the purpose of decreasing the respiratory drive. So all sedatives and opioids decrease the responsiveness to oxygen and CO2. And they have additive effects, as you can see in this experiment with alfentanil and midazolam. Notice the downward slope of the curve. And also in this experiment with propofol and remifentanil. Also, it's important to remember that both propofol and midazolam achieve this decrease in the responsiveness mainly through a reduction of inspiratory effort to a greater extent than of respiratory rate. Opioids have the opposite effect. So, this is a complicated slide, we'll take it slow. The ventilatory demands of every person are determined by the crossing point between the metabolic hyperbola, defined by the CO2 production and the dead space to tidal volume ratio, and the chemosensitivity, the CO2 response slope. Now, in the critically ill patient, there are many common conditions that change both these slopes. The metabolic hyperbola can be shifted upwards, usually with disease, where we have increased dead space. When the patient is agitated or dyspneic and uses the many muscles, has a great effort work of breathing, that will increase CO2 production. But we can also decrease CO2 production with deep sedation, and when we can decrease dead space with tracheostomy. The CO2 responsive curve is shifted upward and to the left when the patient is hypoxemic, acidotic, metabolic acidosis, of course, when the patient is in shock and we give catecholamines, or when the patient has a fever. However, the slope can be shifted downwards with hyperoxemia, metabolic alkalosis, and sedation. And you can appreciate that in a critically ill patient, sometimes many of these things occur simultaneously, so it is challenging to figure out where the curves are moving at each time point. So let's have this example. This is a patient who just arrived from the emergency room. He has pneumonia and septic shock. That means that his or her metabolic hyperbola is shifted upwards because the dead space due to disease is increased, and the CO2 production is increased due to fever, shivering, and dyspnea and increased work of breathing. So this is a metabolic hyperbola shifted upwards. The CO2 response curve is also shifted upwards and to the left due to the metabolic acidosis from the shock percent, the catecholamines that we infuse, and the inflammation. That means that now the patient's ventilatory demands are for a much lower CO2 and greater ventilation, and that means that this patient's respiratory drive is increased. A different patient is the one who is just arriving from the OR. This patient is sedated, a little bit deeply sedated, a little bit hypothermic. So the metabolic hyperbola may be shifted downwards because CO2 production is to the lowest possible level, basic metabolic rhythm. And the CO2 response curve is shifted downwards because the patient is sedated, or even if sedation has been interrupted, there is residual sedation and possibly hyperoxemia. So the new crossing point of the slopes is at a much higher PCO2 level and a much lower ventilation than the normal subject. So this patient's respiratory drive is decreased. I hope these examples can help you clarify this concept. And let's make it a little bit more complicated because that's how it is in the ICU, because we have also mechanical ventilation. Now, in this graph, what you can see is on the x-axis, muscle pressure or PCO2, which normally increase proportionally. Our effort increases when PCO2 increases. On the y-axis, we could have tidal volume or minute ventilation because if respiratory rate remains relatively stable, tidal volume and minute ventilation change proportionally. And we can agree that for a reasonable range of PCO2, our effort and therefore tidal volume and minute ventilation increases proportionally to the rise of PCO2. What happens with mechanical ventilation? That depends on the mode we are ventilating the patient. If the mode is an assist control mode, then clearly the patient will take the same tidal volume irrespective of the level of effort. So this will be a flat line parallel to the x-axis. If we put the patient on pressure support, a given effort will be augmented by the same pressure. So if we are in the linear range of respiratory system mechanics compliance, then tidal volume and therefore minute ventilation will rise like in a parallel slope from the unassisted ventilation. If we use a proportional mode of ventilation like PAV or NAVA, the effort is augmented like proportionally. So it is like the slope of the unassisted ventilation is shifted upward, not in parallel. But in any case, what happens with ventilation is that we can modify the level of PCO2. So there are two other things that are important to understand how mechanical ventilation affects effort and respiratory drive. And this is a very important concept, is how the control of breathing system responds to the decreasing ventilatory demands, and decreasing ventilatory demands can only be achieved with mechanical ventilation. It's the only way someone can breathe for us and decrease the work that we have to make to breathe. So this is an experiment from my professor, from my mentor, Professor Georgopoulos, and he did that many, many years ago. And what they did in this experiment is that they had healthy subjects become breathing with pressure support to hypocapnia, and then breathe with pressure support and PCO2 to the max tolerated. And what you can see is how effort and respiratory rate changes to a quite broad range of PCO2. And notice that effort and respiratory drive decrease as PCO2 decreases, as the subjects become hypocapnic. But also note that while respiratory rate decreases initially, it remains unchanged to a quite wide range of PCO2. This lack of change in respiratory rate, this lack of responsiveness to decreasing ventilatory demands is very important when we assess the patient's response to pressure support or to ventilatory assist in general. We recreated this experiment in critically ill patients a few years back with proportional mode of ventilation, where the patients could change their effort and tidal volume proportionally with the ventilator. And what we saw is that indeed, with increasing assist, respiratory drive decreased, effort decreased, but respiratory rate changed only minimally. Again, as shown many years ago in healthy subjects. And this is the important point I want to make. When we place a patient on mechanical ventilation, the tidal volume is by definition greater than what is determined by the patient's inspiratory effort. If the patient could have an effort that maintained adequate ventilation, then they wouldn't need the mechanical ventilation to begin with. Since I hope I just convinced you that the respiratory rate only modestly decreases when the ventilatory demands decrease, what we can achieve with mechanical ventilation is a level of PCO2 that is below this crossing point. And at this, when we do that, the effort, the respiratory drive decreases, probably corresponding to the drive that would require if we could meet the CO2 slope here. We can even go below the apneic threshold and create periodic breathing in patients. And this has been shown also in healthy subjects. This is a recording of one of my patients, and you can see here flow, airway pressure, and transdiaphragmatic pressure, and see how in a few breaths, by increasing pressure support from 5 to 15, the transdiaphragmatic pressure decreased from 12 to 3, just because the ventilatory demands were covered by the mechanical ventilation. So when we provide with a ventilator a minute ventilation that results in a PCO2 that is lower than the ventilatory demands, respiratory drive is reduced. And we do that often. So this is the experiment. This is the example I just showed you before with a patient with pneumonia. They shifted upward, metabolic hyperbola. They shifted upward CO2 response curve. And this low PCO2 with a high ventilation is achieved with the help of the mechanical ventilation. However, I could offer this ventilation to the next patient I show you, the one that came from the operating theater, who required a much lower level of ventilation. But with pressure support or assist control ventilation, I give him 11 liters instead of the 6 or 8 that he requires. And thus I can decrease his respiratory drive and make him have an effort that would correspond to someone trying to breathe just 5 liters per minute and not 8 or 12. Let's move to the assessment at the bedside. Let's move to more practical concepts. The only way we can accurately measure the respiratory drive is like in this experiment here, where there are slices of brainstem stimulated on the one side and imaged by voltage imaging. Clearly not a practical thing to do at the bedside, because it requires cutting the brainstem in slices, and that is something our patients would not appreciate as an intervention. And we have to measure the signal further downward from its point that it is produced. We either measure the electrical activity of the diaphragm, the pressure generated by the diaphragm or all the respiratory muscles, or the flow generated as a result of muscle contraction. Now think about it as a signal that is produced somewhere and transformed. So this singer is recording in the studio, and this recording is transformed through a process into a vinyl, and then it's reproduced by the player, moved to the speaker, and then we have this output. The extent to which this output resembles or is identical to this, the output of the singer, is obviously depending on the quality of the signal transduction of gone through this process. So if these wires here are damaged, if the vinyl is scratched, if the layer is old and malfunctioning, then this signal will be dumped. It will not resemble the original signal. And this is something that we have to think about when we evaluate the respiratory drive, because we never measure it at the point it is created. So if everything is normal, then minute ventilation and inspiratory flow are indicators of respiratory drive. That means both mechanics, muscles, phrenic nerve, and anterior horns are working perfectly. If mechanics are impaired, then the slope of the pressure generated over time is a good indicator of drive. That means we skip mechanics, but we need perfectly well-functioning muscles, neuromuscular junction, and anterior horns. If muscles are also not working properly, then the signal of the diaphragm, the electrical activity of the diaphragm is a good indicator of drive. But again, even that requires perfect signal transduction through the phrenic nerve and the anterior horns. And if there is damage there, then we have to acknowledge that the signal will be dampened. There is no process that augments the signal. So if we find it high, it is as high as we measure it or even higher. But if we find it low, we have to consider that it may be dampened by any dysfunction of this signal transduction pathway. Methods to evaluate the respiratory drive. We have qualitative, the physical examination. We are able by physical examination to discriminate the patient with high or normal respiratory drive. We cannot discriminate between low and normal. Any high tidal volume and high respiratory rate are indicators of high respiratory drive. However, we should acknowledge that a rapid shallow breathing pattern, use of accessory respiratory muscles, and sign of distress indicate not an absolute, but a relatively increased respiratory drive. A respiratory drive that is and demands that are higher than the capacity of the muscles that are required to perform the task. And we have quantitative indices of respiratory drive. As said before, if everything is normal, tidal volume, inspiratory flow, respiratory rate, and minute ventilation are good indicators of respiratory drive. If not, the slope of a muscle pressure over time or the electrical activity over time are used in clinical practice as indicators of drive. Sorry. Physical examination, remember that volume changes depend on the magnitude of effort, but also the impairment of mechanics. With very increased resistance or increased elastance, a high effort will not create the same volume change as with normal mechanics. The use of accessory respiratory muscles suggests that the diaphragm capacity is diminished compared to the demands. The demands may be even normal, but if the diaphragm is paralyzed, the patient will be obliged to use the accessory muscles. And as I said before, the respiratory rate is not so sensitive to changing demands, although it does always change to the same direction of the demands. It increases when demands increase, it decreases when demands decrease, but not to a great extent in either direction. And let's come to the most commonly used index of respiratory drive in critically ill patients. It is available in oral ventilators, is the P01. The pressure generated against an occluded airway during the first 100 milliseconds of an occlusion. It has the benefit that it is not perceived by the brain, not affected by mechanics, and easy to perform. It has this important limitation. It is affected by the shape of PEMAS. So if someone has a muscle pressure output that has this shape compared to someone who has this shape of pressure output, they both have the same output, but if I measure here, we'll find a different value. There's another problem. There is a variability between our ICU ventilators, how they measure things. And that both these problems result in a significant problem in determining the reference values. There is another issue that is quite unexplored, that is at which level of muscle weakness will the P01 be affected and not representative of the respiratory drive. If someone is completely paralyzed, imagine someone with a complete and severe injury in the C3, so no phrenic nerve at all, or no accessory muscles, then they will have a respiratory drive, but that will not be translated in any pressure generation. So there is an issue there. This is the original paper describing the occlusion pressure by Milik Emily, and you can see many of his friends making the maneuver here. And you can also see the difference in the baseline, or in the, it's not baseline, it's PCO2 of 50, but the difference in this value between these healthy subjects. That is the problem of the reference value I was telling you about. But in all cases, there is a great response with increasing PCO2. And this is an example of a recording from one of my patients. And this is the problem I was telling you with the shape of muscle pressure. In this case, we have a deep transdiaphragmatic pressure swing of 5.7, a slope of 9.4. But when we measure the P01, we find it 2.1. And due to the difference in shape, in this case, where the swing is almost double, the slope is quite higher, 14 compared to 9. The P01 is 1.4. So different people can have higher or lower drive that is not represented in P01. However, in the same person, the change in P01 is reflective of the change in respiratory drive. And there's this other problem highlighted by Urentelius in this paper, that different ventilators measure P01 differently and have different accuracy. Therefore, reference values are really, really problematic for P01. We tend to consider a range of about 1 up to 4 to be acceptable for the critically ill patient, but this has to be taken into great consideration and not used as absolute gold standard values. When a person is very calm and doesn't have alteration in mechanics, they may have a P01 less than 1, and that could be normal. And COPD patients are walking around and speaking very comfortably and have a P01 that is much greater than 4. So remember that you should not stick to absolute values in your practice. Other indices of respiratory drive include the change of the whole muscle pressure over time, which is not affected. It is affected to some extent by mechanics, but it does capture the shape of muscle pressure, either of all muscle or PDI. It requires the measurement of esophageal or gastric pressure for PDI. And again, in this case, we don't have reference values at all. The electrical activity of the diaphragm, the slope of the electrical activity over time, is a processed signal that is not affected by mechanics and muscle strength, probably. It is not affected by the shape of the mass, but it does require this special catheter to measure it. And there are significant issues in the signal transduction that also precludes any reference values. So I will try to give you some practical examples. So we have the respiratory center in the brain, and the signal is transferred to the phrenic nerve and the respiratory muscle nerves, and the neuromuscular junction, and then to the muscles and the mechanics that will be of the that will be moved to be translated in a signal. And let's think about our patients. The respiratory drive can range anywhere between high and low. The condition of the muscles of the patient I have in front of me can be normal, so normally strong, or it can be very, very weak to almost non functioning. And the respiratory mechanics can range from normal to severely impaired. Let's think about how these indices of drive, what I see with my physical examination, with the measurements of ventilatory variables, and with a slope like a P01, how it will be affected by changes in this in all these three conditions. So, a practical approach how to think about the respiratory drive. The first step is, and that's my advice, when you look at a patient and you think about evaluating his respiratory drive, form a pre-test probability. Consider the factors that determine the respiratory drive of your patient. Think about where would their metabolic hyperbola be relevant to the normal. Is their CO2 production increased because they are breathing hard, they are agitated, they are moving all their muscles? Do they have a very high dead space? You could figure it out using the simple measurement of ventilatory ratio. Or is everything almost normal or even decreased because the patient is very calm and has a tracheostomy, so very low dead space? Is the patient acidotic? Do they have shock or fever? Or do they have residual sedation, metabolic alkalosis, for example, as a result of diuresis? Or are they hyperoxic? Make a pretest probability or where the respiratory drive is, over there or over here. Then, before making a measurement, consider the factors that affect the signal transduction. Think about the pathway integrity and what you know about it. If it's a patient that you have in your ICU, you should know a lot of their pathway integrity. And when you evaluate indices of respiratory drive, acknowledge their limitations and also consider, if you are applying mechanical ventilation, that tidal volume, minute ventilation are affected by the ventilation that you provide and not only by the patient's drive. So, some examples. This patient has a normal respiratory drive, strong muscles, no muscle weakness, and normal mechanics. In this case, what you see is what you get. Normal drive, everything is normal. Physical will be normal, measurements will be normal, P01 will be within the normal range, and that's quite obvious. High respiratory drive in a patient with no muscle weakness and relatively normal mechanics. You will see this high respiratory drive. It will be obvious in the high tidal volume, in the large displacement of the chest wall, high minute ventilation, and if you measure P01, that will also be high too. But what happens when the respiratory drive is low? If the muscles are strong and the mechanics are normal, then with your physical examination, you will see a low minute ventilation, low tidal volume, low respiratory rate, low P01. The same will happen with weak or impaired muscles and impaired mechanics. Everything will look low. But what happens in more complicated cases? The patient with a low respiratory drive and modest impairment of muscles, modest impairment of mechanics, but you have added the mechanical ventilation. Then with physical examination, you will not be able to see much. Tidal volume and minute ventilation will be affected by your mechanical ventilation settings and can range from normal to high. However, you will be able to capture the low drive from the low P01. And this is the most challenging case, and this is the patient which is at most risk of being undertreated. The patient with a high respiratory drive, but weak muscles and impaired mechanics. In this case, especially if you add sedation and mechanical ventilation, physical examination may be very confusing. Tidal volume and respiratory and minute ventilation can range from low to high depending on the ventilator settings. P01 will probably be high, except if muscles are very, very weak. So do be careful in the patient where you have suspicion of high respiratory drive and weak muscles, because what you see has to be interpreted with caution so that you will not consider a patient as having low drive because they cannot show the high tidal volume or high minute ventilation that corresponds to their high drive. A very big discrimination between drive and output will be perceived by the patient as dyspnea and suffering. So this is the point I would like to emphasize again. Distress may be present, but sedation may mask this distress, and sometimes we cover our patients with dressing or bed with sheets, and we don't see the use of accessory muscles. So do be very careful here in this case. And most importantly, once you form a hypothesis, the most important information will be, you will take it by evaluating the response to the intervention you are making, depending on what you think of the patient's respiratory drive is. Any change of respiratory rate of indices of drive is much more accurate than any single value. And remember, high respiratory drive is associated frequently with dyspnea, while low respiratory drive is associated with weak efforts and prolonged mechanical ventilation. And with that, I will stop, hopefully I'm on time, and I will now be able to take any questions you have. Thank you.
Yeah. Thank you, Dr. Katerina ma'am, for a wonderful talk on respiratory drive. Very simplified, such a complex topic. So, ma'am, please stop the share screen.
Yeah, try.
Yeah. So, if I request the audience, if they have any questions, please put up your questions. Ma'am will answer them. Meanwhile, ma'am, I will just put up some points for you to discuss for everybody. So the first point is, ma'am, P0.1, which is very relevant to everybody. Is it affected by muscle weakness, respiratory muscle weakness?
So we do not have trials showing that it is affected. We can understand that if we paralyze completely a patient and we don't ventilate them, but they are awake, they will have a high drive, but no P01 because they don't have a muscle to create it. So it is reasonable to assume that at a certain level of muscle weakness, P01 will not represent the actual drive, but we do not know which is the level of muscle weakness that prohibits us or gives false low values of P01. Until we do have such data, I advise everyone who evaluates a patient to be very cautious. For a patient, if you, for example, measure in a patient a maximum inspiratory pressure of 10, that is 10 times lower than normal, don't rely on absolute values of P01 to evaluate the respiratory drive. If you try to titrate, assist using P01 in this patient, it is very likely that you will fail. But it's also very likely that you will see the patient become tachypneic once you try to decrease support just because you measure the P01 of, for example, 1 or 2.
Yeah. Thank you for the answer, ma'am. Then another question related to P is 0.1. So how is P 0.1 and respiratory rate and tidal volume linked together? What can you say about this?
Okay, so um, the way the control of breathing system works is that when ventilatory demands increase, we increase initially tidal volume and therefore P01 more than we increase respiratory rate. Once we approach our total lung capacity, it is inefficient for the control of breathing system, for the system in terms of energy, to try to further augment effort. And therefore, at this point, respiratory rate increases more. In our critically ill patients, when muscles are weak and mechanics are impaired, this point can be reached at much lower levels at much lower volumes than total lung capacity. So when a patient is not able needs to increase ventilation, but is not able to generate more tidal volume, cannot increase effort more, they will go to, so to say, plan B and increase respiratory rate more. In either case, P01 increases in both, but it remains at the very high levels when respiratory rate starts to rise significantly. P01 is already high because effort is already high. And at this point, you may not able to capture the further increase of demands that the respiratory centers are trying to compensate because the patient cannot further increase effort and they are increasing the respiratory rate.
Thank you, ma'am.
That was a little. I think that might have been confusing. If you want.
Yeah. So just a couple of questions, ma'am, more. So, ma'am, about clinical evaluation. So, how do we clinically actually evaluate this respiratory drive if we can at all? What is the best way, and what is the utility in our day-to-day management of the patient? We take the rounds at the bedside. So, how do we assess respiratory drive, and how does it help us clinically?
So, the one important, one common mistake, so to say, is that we have patients over-assisted. So if I see a patient that is very calm, seems very relaxed, and tidal volumes are in the range of high normal, and the respiratory rate is in the range of low normal, and the P01 is also in the range of low normal, and in the physical examination, I see no accessory muscle use, it is quite likely that if I provide pressure support or assist volume, I'm over assisting this patient. And I should be decreasing assist until I see the patient having signs that they are trying too much, and then I should step a little bit backwards and titrate assist probably to some higher level but lower than before. That is one important factor that we're assessing respiratory drive helps us promote weaning. Another condition is that another thing that should be pointed out here is that I may measure the patient's effort and find it weak if I have made the patient alkalotic or if I provide assist. It takes a few minutes before CO2 increases, before metabolic pH reaches 7.4, so that the patient is respiratory drive increases back to normal. So if you find a patient that is on diuresis and has a pH of 7.47, and you see that they require a high support, and you say, oh, I cannot win this patient, the problem is not the muscles, the problem is the ventilator and the diuresis. So patient may be fine, maybe even able to be disconnected from the ventilator once we restore his or her respiratory drive by decreasing assist and correcting the metabolic alkalosis. On the other hand, we may have a patient who has very high drive and makes a great effort and or uses the accessory muscles. And when respiratory drive is high, it is not clear at the moment whether we should correct it. We should adjust the ventilator to satisfy these high demands, because then we place the patient at risk of ventilator lung injury, because maybe the drive is very high, is abnormally high due to inflammation and acidosis. And then the patient can create, even in an assisted mode, lung injury. And at this point, we should try to pharmacologically decrease the respiratory drive so that the demands decrease, not that we cover these high demands with the ventilator.
Thank you, ma'am. Then another question is about acute brain injury. Different situations lead to different kinds of acute brain injury. For example, there's a patient
Yes.
with encephalitis. So it has been my observation, and is there in literature also, that the respiratory center may respond differently to encephalitis or other acute brain injury conditions. So it can lead to both an increased respiratory drive as well as a decreased respiratory drive. Right. So where is the difference here? How do you understand this?
Yes. So normally the cortex has a low depressing effect on the respiratory drive. So if you go to a clinic where people in chronic vegetative state are ventilated, they usually tend to be slightly hypocapnic. So acute brain injury that affects the cortex increases the respiratory drive by removing this depressive effect of the cortex on the respiratory centers. That is one thing. Injury due to altered blood-brain barrier to the respiratory center can cause either high respiratory rate or more frequently ataxic breathing. This is important to acknowledge because we shouldn't think about this increased respiratory drive as something that we should address these demands of the patient. This is an abnormally high drive, and we shouldn't try to satisfy these high demands by providing ventilatory assist. We should rather try to pharmacologically again decrease the respiratory drive until the acute condition subsides. Now, for the patient who has brainstem injury and depressed respiratory drive, but is not brain death, this may be a patient who will require prolonged mechanical ventilation, because unless the brainstem recovers, there is not much you can do to correct things.
Yeah, thank you, ma'am. Final question about weaning failure. So, is there a fixed pattern between weaning failure and respiratory drive?
No, obviously not. But do be careful of the easy fix. The patient who has weak effort because the respiratory drive is low because of things that can be modified: residual sedation, metabolic alkalosis, and overassist. If you have a patient with a pH of 7.5, they are not going to breathe. They will have very low effort, and they will have a high CO2 until they normalize their pH, because that's what their brain wants. and that shouldn't consider as a winning failure. On the other hand, patients with very high drive and weak muscles cannot compensate, cannot satisfy their demands, so they will fail winning because they will be exhausted. And this is something that we can predict.
All right, ma'am. Thank you, ma'am, Dr. Katerina Vaporidi, ma'am. Thank you so much for all your talk and detailed answers. It was wonderful, very educative, and the audience also loved it. And soon we shall put it up on our YouTube channel. Thank you very much, ma'am. Take care. Bye bye. And I thank the
You're welcome.
audience. Yeah.
Welcome. Bye-bye.
Bye bye. Thank you. Good night, ma'am. And I thank the audience for the patient hearing. Thank you, everybody. Bye bye, ma'am. Bye bye, everyone.